So good morning everybody. So in the last class we have started with the corticosteroids. In the first slide, what it is there, you need to ask your friends. Because here we are trying to explain what are the life-saving conditions where we can use our corticosteroids and the adverse effects which can be very dangerous also. So we started with the introduction from where our normal corticosteroid synthesis will take place. So this is in brief how the corticosteroid synthesis occurs in the body. Okay, starting with cholesterol, pregnenolone, okay, 17-hydroxypregnenolone. In the down you can see corticosteroid and conversion to estrogen and androgens. What are the three layers of the cortex, GFR, zonal glomerular, vesiculata, reticularis. What all is synthesized? Why we call it as glucocorticoids? What is the action of mineralocorticoid? All these things we have seen. So coming to the classification, I want to add more drugs. Okay, so the classically used drugs are the corticosteroid, hydrocortisone. Definitely is relatively newer one, where the per kg body weight has been raised to 4 mg. Otherwise, all the steroids can be over. The classical one which we use is prednisolone, 1 mg per kg. Then methylprednisolone, here the dosage is about 8 to 10 mg. Triamcinolone, we told that we are using it in keloid, and long-acting drugs, dexamethasone, betamethasone, they find their use in the oral drugs for skin infections and also in cases of asthma. So some of the other agents are the arformoterol, that is topical. Beclomethasone, you already know it is for inhalation. Beclomethasone and budesonide, they form the part of our beta-dose inhalers. Then clobetasol, the popular topical drug, desonide, they use it for combination with clindamycin for acne. Fluocinolone, flunisolide, they form the part of the intranasal sprays also. They are used for topical, fluticasone for inhalational. So biosynthesis, what is stimulating it? Corticotropin release hormone from the hypothalamus. Then under that influence, pituitary produces ACTH. Then from the adrenal gland, we get this cortisol. Based on the cortisol levels in the plasma, there can be feedback inhibition. So pharmacological actions, we have direct anti-inflammatory, anti-allergic and immune responses. Almost on all the systems we have the corticosteroid effects. Effect on BP, we told mineralocorticoid induced hypertension, lipolytic effect, buffalo hump, bronchial smooth muscles, we already know how we are using it. So this diagram, it would be nice if you are able to reproduce these things. Okay, how immune system is altered, net loss of amino acids, gluconeogenesis is taking place, free fatty acid mobilization. So this diagram is showing that corticosteroid can have both cytoplasmic and nuclear receptors. Okay, how they are activating the co-activators and co-repressors. Okay, based on this co-activators and co-repressors, we have the beneficial effect and the adverse effects. So in this diagram, we saw that based on the stress how the body can react. Okay, so there is a delicate balance between the insulin, glucagon, and the corticosteroids within the body. Okay, so based on that, how the gland can act. Okay, once under stress, norepinephrine is released, the glucose levels will increase. Then, based on the action of the adrenaline and noradrenaline within the body, there can be increased blood pressure, increased metabolic rate. Okay. So, how water is reabsorbed under the influence of aldosterone? You know that mineralocorticoid, how it produces aldosterone-steroid-induced proteins, how the sodium potassium ATPase is acting at the collecting tubules. So, if you are familiar with the action of the potassium sparing diuretic, you can just remember it. So, carbohydrate and protein metabolism, we told that there is gluconeogenesis but decreased peripheral utilization of the glucose. So, net result is increasing the plasma glucose levels. That's why we should be very careful while using these drugs in cases of diabetes mellitus. So, lipid metabolism, Vahanaham, mood case, there is central mobilization. So, Addison's disease, there can be shrinkage of the ECF, cellular hydration levels are altered, hypodynamic effect state of CBS, all these things. So, aldosterone effect, sodium reabsorption, potassium is excreted, cardiovascular system, mineralocorticoid induced, hypertension will be there. So, steroids in the initial phase, you can get a good body buildup, but later there can be steroid induced myopathy. CNS, we told that there can be excitation, increase in the mood and behavior. So, if it is at a toxic dose or the higher dose, we can get this insomnia, anxiety, and still higher doses they can be shiddiness. So, in the blood, we saw that there is increase in the number of RBCs, platelets, and the neutrophils, but the WBC counts like lymphocytes, eosinophils, and monocytes which are decreased. So, we are finding its use in organs, lymphomas. So, in the GIT, there is increased acid secretion, so it is a GI irritant. So, the prime effect of this glucocorticoid is decreased immune response, so H. pylori infection can flare up. So, hypersensitivity reaction that we found our glucocorticoids very much helpful. Okay, so suppression of all types of hypersensitivity and allergic reactions. So, you can tell it is the drug of choice in most of these conditions. Maybe it's a skin infections, Stevens-Johnson syndrome, exfoliative dermatitis, pemphigus vulgaris. Most of the skin conditions or the allergic conditions, we can use this. Angiolytic edema. Okay. So, in case of transplant rejection also, we find their use. So, coming to the anti-inflammatory effect, we all know they can they are very good immunosuppressants. So till now we are knowing the NSAIDs. So NSAIDs is non-steroidal anti-inflammatory drugs, but here these are the steroidal. So basically you know how the NSAIDs act, that is blocking of the oxygenase enzyme. But where our steroids act? So coming from the pathways initially, under the influence of phospholipid A2, you know that there is from the tissue membrane, cell membrane, we are getting this arachidonic acid. Under the influence of this phospholipid A2, there will be subsequent lipoxygenase pathway and cyclooxygenase pathway. So here, almost all the steps will be blocked by our corticosteroids. I will be displaying those slides. So there is suppression of the T cell activation, cytokine production, suppression of the mast cell degradation. Can you we remember in the last class we discussed about the mast cell stabilizers, nicotine antagonists. Okay. So decreasing the capillary permeability and indirectly they inhibit the degranulation of this mast cells and basophils. So reduce the prostaglandin, leukotriene and platelet activating levels. So by altering this phospholipase A2 activity. So here this is the normal pathway what we see. Okay, membrane phospholipids, from there under the influence of phospholipase A2, arachidonic acid, lipoxygenase, cyclooxygenase. So from the lipoxygenase, here the inflammatory mediators of asthma and other inflammatory mediators from the cyclooxygenase pathway, they are released. So the drugs what we know are the NSAIDs, okay, where COX is inhibited, and here are the steroids. So by blocking this first step, we can act on both the mechanisms. Okay. So by blocking these enzymes, we know that there are some beneficial effects also, there are some bad effects also. So we have certain drugs now, what we call them as selective action on the glucocorticoid receptors, what we call them as SERGA. Okay. Selective glucocorticoid receptor antagonists, something like SERMs. During the SERMs, selective estrogen receptor modifiers. Where do we use them? Chlorothiazide citrate, tamoxifen, where it is breast cancers, uterine cancers. Okay, so in a similar way, there are some cancers depending on the glucocorticoid receptors also. So where we use this aminoglutamide, trimestane, we will be learning it in the later slides. So effect on immune response. The cytokines, which are the primarily immune response molecules, their synthesis is blocked, action is blocked, and effect on other inflammatory mediators. All the three steps are there. Okay, so in the synthesis or synthesis of the cytokines, okay. So we know that this glucocorticoids are gene active drugs, that means they act by acting on this genes which are responsible for bringing what is inflammatory mediators. Okay, so they inhibit the transcription, binds to the stimulatory transcription factors, accelerate the degradation of the mRNA coding for this cytokine. So transcription is inhibited, okay, and action of cytokine-induced transcription factors, that is coactivators, all those things will be blocked. So increased expression of lipocartin, that inhibits phospholipase A2, which we saw in the previous slide. decreased expression of the enzymes involved in production of the inflammatory mediators, that is phospholipid involved FOX, that is also inhibited. So the enzymes coding for this breakdown of these inflammatory mediators, that is AC inhibitors, neuroendopeptidase, all these endogenous inflammatory mediators, their breakdown enzyme level will be increased. So here you can see, if you can reproduce, this will be good. Okay, glucocorticoids, their action on eosinophils, T lymphocytes, mast cell, degranulation is prevented, macrophages. Okay, here you can see cytokine levels is decreasing. Decrease the apoptosis. Epithelial cell, again cytokine mediators levels are decreased. Endothelial leak is decreased. Okay, it is by endothelial leak you get this inflammatory mediators outside the cell. Okay, smooth muscles, there is again decreased cytokine action because glands there is decreased mucus secretion. So growth and cell division. So in most of the cases of most of the children, we try to avoid this glucocorticoids in the earlier stage, either in asthma or in nephrotic syndrome. But if it is used, we see there is standard growth or the retarded growth, delayed process of healing, all these things will be there. Calcium metabolism, we know that these glucocorticoids are involved in the osteoporotic mechanisms. How it takes place, it is by decreasing the intestinal absorption and increasing the renal excretion. So by causing this calcium loss, you can bring about spongy bones and there will be chances of vertebral collapse. So there are, for respiratory system, for bronchial asthma and chronic obstructive pulmonary disease, these are the drugs which have changed the way we think about the asthmatics and the COPD patients. In the earlier phase also, they are needed for the synthesis of this surfactant or the surface active agent, which is needed for the prevention of collapse of this alveoli. Okay, the most potent and most effective anti-inflammatory in this system, but the action, if it is given over, it is little bit delayed. We have the alternatives now, inhalation of steroids. So thyroid, it inhibits the thyroid stimulating hormone versatility. So coming to the uses of these steroids uses we can divide them into endocrine users and non-endocrine users. So in among endocrine users, we have major thing, that is replacement therapy. So and also diagnostic tests are there. So in case of this replacement therapy, so there is congenital adrenal hyperplasia. Okay, in these conditions we can use this. So adrenal insufficiency, it can be acute or chronic, and due to abrupt withdrawal of steroid therapy. So steroid therapy, we should know that it is not withdrawn suddenly. Like for example, antibiotics we use for 3 days, 5 days, we abruptly stop it. But in case of steroids, the dose is tapered slowly, about like 2 milligrams to 5 milligrams. We start the dose with highest dose what is given to the person. 60 kg, 60 milligram we start. Then after 3 days we reduce to 30 milligram, then to 15 milligram, then we withdraw the drug. And by in the last phase we can use shift from long acting drug to shorter acting or intermediate acting drug, and then we stop using these drugs. So in case of adrenal insufficiency, maybe acute or chronic, we can use this. Abrupt withdrawal, chronic infections, tuberculosis. There are some conditions such as biliary tuberculosis. Okay, so where there is complete haziness of the lungs. You might have seen something like stars in the sky pattern. Biliary tuberculosis X-rays you have seen? Yes? So, in these conditions, and in order to prevent the adhesions, okay, in case of extrapulmonary or the pleural effusion due to tuberculosis, in these conditions, we use this drug. Due to surgery, hemorrhage in HIV, there can be adrenal insufficiency, where we can use this steroid for replacement therapy. So, congenital adrenal hyperplasia due to deficiency of protein hydroxylase enzyme. So, you saw that this enzyme is first step in the biosynthesis. Okay. After the action of the enzyme desmolase, there is action of this enzyme where we convert prednisolone to successive products. So the treatment regimen here is for acute, chronic and congenital adrenal hyperplasia. Okay, IV replacement of sodium chloride and fluid. In the last class we discussed that this glucocorticoids in the renal system, they also have the action such as the mineralocorticoid. So they are involved primarily in salt and water retention. So IV hydrocortisone 100 mg start followed by 100 mg 8 hourly. For chronic adrenal insufficiency, we can use this hydrocortisone, prednisolone and HYDROCORTISONE. So anti-inflammatory uses for this rheumatoid arthritis, we have this DMARDs. Okay, so along with that, for acute prevention of this conditions, we can use this drug. Later, we can replace them with the other more safer drugs as an adjuvant with NSAIDs in severe cases. In osteoarthritis, it is a tricky condition. Okay, because the patient will be having pain and by the use of steroids, there can be some deterioration. But if the patient is tired or so fed up of his infection, the state or the wear and tear, there will be decreased joint mobility also. So for immediately relief of the pain, you can use a course of steroid. Later, you can replace them with the NSAIDs. We have this Cameron 4, we have this steroid 50 days. All these things will help. But initial few days, you can go with this. And intra-articular steroids are more popular among the patients. So in rheumatic fever, in severe cases with carditis, congestive heart failures, we can use them. Gout, NSAID in failed cases, colchicine failed cases, intra-articular infusion. Vasculitis, can use this. So intra-articular steroids we use for triamcinolone. Okay, so osteoarthritis is a inflammatory condition or non-inflammatory condition? Yes? Itis is there, no? Osteoarthritis. Itis is there, means? So now we have replaced this NSAIDs with the tramadol, paracetamol, considering this osteoarthritis as a wear and tear of the joints without inflammation. Okay, there is less inflammation, purely considering, but after the long-term use of these NSAIDs, we may get this hypertension and all. So now they are trying to replace this Rabdol and these NSAIDs with Rabdol and paracetamol, thinking that it is a non-inflammatory process. So knee joint, shoulder joint, tennis elbow, all these conditions we can use this. What is ITP? Do you remember Beradinella Boy? Movie, famous movie. No. Yes. So what are you doing? Hemolytic anemia, idiopathic thrombocytopenic purpura, chronic hepatitis, alcoholic hepatitis. You can use this drugs. So in case of nephrotic syndrome, this is the drug which saves the patient's life. Okay, we use this drug at the maximum dosage. Okay, maximum possible dosage will be started. Nephrotic syndrome, renal disease secondary to SLE, systemic lupus erythematosus, renal sarcoidosis, and glomerulonephritis. We can use this drugs in organ transplant combined with the other immunomodulatory agents such as cyclosporin, azathioprine. Anti-cancer is not over for you. Over. So among the anti-cancerous agents, we classify them into cell cycle specific, cell cycle non-specific. Okay. In these agents, we have some anti-metabolites. These are this azathioprine. Okay. And cyclosporin is the which group? First group. Some fluid is oral. Okay. In organ transplant, we have to use these drugs for a longer time. Okay, so prednisolone or beta-prednisolone is always tried. So they will be on lifelong therapy with this device. Anaphylaxis, angiolytic edema, serum sickness, all these conditions, adenol is the drug of choice. Adenol, what drug we use? One in 1,000, one in 10,000, one in 1 lakh. So if you don't know today, at least go home, see. This will be common question in bio. Okay. So allergic reactions can be suppressed by corticosteroids as supplement. Intranasal administration will be done with this fluidside in allergic rhinitis. So bronchial asthma, this is the drug of choice and used in almost all the forms in this condition, inhalational, intravenous, oral, all the three routes are used. Okay. So In severe asthma attacks, we can use this IV hydrocortisone. Oral nasal prednisolone can be used. Okay, and we use them in the form of nebulization and multi-dose inhalers. So here, this beclomethasone propionate, they can be more active when they used in the form of aerosols. Okay. So severe infectious diseases or some reaction is there where we are worried about, for example, pleural effusion, where we are worried that these pleura may collapse. So in such conditions, we use this drug to prevent the immediate inflammatory response. Okay. Indicated for severe infectious diseases to tide over the crisis and to avoid the complications. So Neocystis pneumonia, HIV infections, meningitis, Lepra reaction, and septicemia. Sorry, done mistake. Again, ocular infections, if they are very severe, both the palpebral and the bulbar conjunctiva, there will be chances of adhesions. In these conditions, they form a very important drugs. Okay. So allergic conjunctivitis, iridocyclitis, keratitis, all these areas we can use these drugs. We need to remember these drugs when we are giving